Hello, how's everybody doing today? It's our pleasure to be here to discuss establishing a focal therapy program for prostate cancer with a Q&A session. People joining me in the Q&A is Kara Watts from Montefiore, Sri Vourganti from Rush, Rafael Sanchez Salas from McGill. We'd like to really extend a big thank you for the Sonoblade Corporation for sponsoring this event today. The event will be recorded and live streamed on our YouTube channel for further follow-up. Our goal is to go through a quick 20-minute talk to spark ideas and questions for the people who have signed up for the webinar today. Just to give you guys some housekeeping, over 200 people have signed up for the webinar, so we're really excited about that. And we hope that we answer some questions. Focal therapy is something that's growing quickly. The society has positioned itself to really help people with no experience and just interest to be able to hopefully get them through the basic steps to build a program for themselves. Almost every academic center across the globe has started a focal therapy program, and it's our pleasure to be here today. I really want to thank the sponsors as well as my panelists, and we're going to get started, okay? Again, my name is Dr. Art Rastenhad. I'm from Northwell Health, and I'm also on the executive committee for the Focal Therapy Society. Establishing a program. Focal therapy, what is it, first of all, for people in the audience that are not familiar with it? It's a minimally invasive treatment option that attempts to destroy the cancer or control prostate cancer's risk of progression while sparing the normal healthy tissue. What's the rationale? It's because a lot of men are looking for options that can benefit the cancer outcomes as well as the quality of life outcomes. And most of our prior treatments weren't paired so well. So there was a high risk of complications or adverse effects that people were less prone or less apt to pick these treatments. And our goal has been to minimize this. But who's a candidate? Typically, it's localized intermediate risk prostate cancer. We are doing some trials to look at high risk disease, but right now the sweet spots are around Gleason 7, grade group 2 and 3, and some patients with low risk prostate cancer with MRI visible disease. The techniques there's a plethora. There's cryoablation, HIFU, IRE, laser, TULSA, Insight Tech. And each of these has their own pros and cons. I'm not going to cover that here, but maybe we can cover some of that in the QA session. The benefits of focal, I kind of alluded to that in the prior slide. It's cancer control without the side effects, usually an outpatient same-day procedure. And the side effects I was discussing are erectile dysfunction, urinary incontinence. Those are the primary two issues men have with the treatments. And again, it's an outpatient same-day procedure. And I think the most important thing we're learning today, that it doesn't burn the oncologic bridge. The oncologic bridge I refer to is, are you available to future treatments? Almost all the focal therapies still allow people to undergo surgery and or radiation if it's needed. And why is this so important? It's because 40% of men have treatment regret after prostatectomy. And from a physician point of view, I'm not a big person, a fan of dinging the gong when you're done, you're cured. Prostate cancer is a lifelong process. And we're going to talk about that because your focal therapy and prostate cancer care should be a complete care cycle management from the point of the elevated PSA all the way through treatment. And in the rare or adverse event of a recurrence, we want to be able to address these items. And I think focal therapy and the other treatments are for the entire patient. And I'm going to talk about looking at how they do for their outcomes and what's important. But what are the essentials, like just to get you out of the box and how to get a program started? First is your communication loops with your teams. Radiology, pathology, and urologic oncology or urology all have to be on the same page and have a feedback loop because it really all happens with imaging and biopsy, and to be able to put those two pieces together and then use the treatment modality and take the information from the initial diagnostic process to then apply that to the treatment. Favorite slide, it's been morphing over the years, but it is garbage in is garbage out. And this is a famous quote, but it's really applicable here in focal therapy because we don't really know what we don't know. How can you recognize a high quality MRI? Did the person that in some scenarios refer you a patient do a good or adequate fusion biopsy and you really understand where the burden of disease is? Are they doing perilesional sampling? Was there good co-registration? Because these factors will have significant implications into planning treatment and especially for the patient, the outcome of the procedure. Let's start with ordering the MRI. I always try to support my radiologist because they do a significant amount of the lift here. But we have to have high quality MRI. Typically, we're using 3 Tesla greater than 1.5 Tesla. Even in patients with hip replacements, at our institution, we choose to do 3 Tesla. I know the diffusion weighted imaging will have some artifact, but one good D2 and a good DC helps significantly more than 3 average scans. And we really encourage our patients to do an enema. Why? Because the air in the rectal vault at the time of study can cause artifact, which can impede the quality of the imaging acquired in your diffusion weight imaging. I'm not going over MRI today, but DWI does play an important role. It looks at the density of tissue. Some people have written that and published that DWI can be a predictor for recurrence after focal therapy. I still rely on my dynamic contrast enhanced MRI. But when ordering the MRI, make sure we have the diagnosis code, what's the indication, what are your findings as a urologist, and is this post-focal? And of course, you don't do partial nephrectomies without imaging. Radiologists should not have to interpret imaging without the history. And I think it's important to put that in the report. Team building. Unless you're someone that has the skills of a radiologist, interventional radiologist, and a urologist, it's extremely difficult to do this on your own. And of course, as I mentioned before, it's about management of the entire patient. So our radiologists, our MRI is not obtained in a vacuum. We have MR physicists that go through sequence development and optimization. Even though you and I could have the same exact MRI machine, the settings inside of that machine for each image acquisition of the sequence are specific and have to be tuned to that specific magnet. That gets you to the MR techs. Our techs are very important. They're the ones that talk to the patient. They acquire the image. They recognize if there's any artifact at the time of the study. All this will result in a higher quality MRI. If your techs aren't on board, you're going to have a poor study or have a higher probability of that occurring. Your GU pathologists, of course, they're indispensable. They really help you understand the burden and the type of disease you're dealing with. For urologists, at our institution, we have training for transperineal biopsies, fusion biopsies. We look at outcomes, and then we supervise and support our colleagues to learn focal therapy. Your office staff, how patients feel, what's going on, how do we take in the data, and specifically you're not doing the treatment, how do we get that data back to our referring urologist of what's happened to them? We leverage ACPs in our practice. They play a significant role in the intake, assessment, and risk stratification of the patients with prostate cancer who are at risk of that, which I think is really important. So it's about a team. It's not just about you. This is always a challenge due to the burden of the number of MRIs that are being read these days. And in academic institutions, there's sometimes a limited number of radiologists available, or they're spread thin reading ERs and different studies. You need a dedicated team. You need someone like my radiologist currently here that I work the most with is Howard Borskin. He's always available. All our partners love him. He's a chief of a radiology department at a hospital, but he's always available. And he's learned a lot from the feedback. And we know that you need to at least read 50 MRIs a year to maintain some adequate skill in MRI interpretation. We typically like to have consensus reads if you're new to the program. You read it, then a senior physician also double checks to make sure there's concordance, because we all know that there's a 20% discrepancy in MRI interpretation when looking at prostate MRIs. And the rad path follow-up, it's a closed loop system, right? We did the biopsy, you did it, you looked at the film. So please don't forget about your radiologist. They need to learn. It's like these two kids in the corner trying to push a bale of hay. It ain't easy. And if you don't approach this the right way, they're never going to get any work done and they're not going to improve. Treatment planning, historic. This is how we do focal therapy planning. It doesn't matter what platform you're on. In the left screen, we're looking at the MRI. We can create a 3D map of where the disease is and what we want to treat. And then you can take the same information, which is a slightly different case. I took a still shot of an anterior tumor. We outlined where the tumor was and what we think the margin should be in the area This does not have the margin listed. We're just looking at the highest risk area and where it is. And then you would, in your mind, decide to do this with drawing in additional ROI or place the probes appropriately to get an adequate coverage. It depends on which modality you'd be using. This is another example of fusion with cryoablation and using a standard fusion platform. I've removed all details of the company, but the idea is that we can see where we think the sphincter is, where we see the apex of the prostate. Can we place the needle inside and you see how the prostate rolls away? This is a common mistake I see. You're not low enough to get to the where the angle you're hitting the front of the prostate and it's rolling away. So it's really important to understand where areas are. And then you want to look at your ablation zone. Do you push the ice far enough? Are you within 5 millimeters of the edge? It has to be 5 millimeters past your edge. Hold on 1 second. Dr. Sanchez Salas is having trouble getting into the meeting, unfortunately. But this is an idea of just how fusion is done. What's the future look like for this? This is what I think is exciting. Now, with the new technology, you can have your ROI of your lesion. You can automate and set a margin to draw around the area in the z-axis. The most common thing that we see is that people don't work well in the z-axis. I mean, the apex to the base. So you undertreat the apex or undertreat at the base. Therefore, that's the area for the most common places for recurrence, especially when people are starting to learn. And I really want you all to take this in because this is probably the most important part. When you're planning, please remember the z-axis. I always try to explain to everyone because that is the most common area. People are really good in the XY, left and right, above and below in this plane, but towards the apex and towards the base, it can be missed. And I think this is a great example of how now technology, you can see how far to push the ice. The thing in cryo, you can't see your treatment because you can't see through ice. But what's nice when you do fusion, you can use the opposite side of the prostate, other landmarks, and make sure that you still maintain good co-registration in the process. And as we work through it, I think you can pick your tools. You can now visualize what the treatment's going to be before. This can be done with cryo, laser, IRE. So it depends on technology. HIFU has inputs with MR Fusion co-registration for your planning. All this is coming together on all the platforms. Recently, the Focal Therapy Society had a communication. We really think fusion and MRI are key. Cognitive alone could lead to more errors, and it's important when you're starting to use as much of the tools that you can to get the best outcomes for your procedures and your patients. This is just another example of the future. You're taking full care cycle management. You've used imaging to make diagnoses, and now you can use that same information if you're going to do surgery or have planning, that you're able to create a 3D model of the prostate to navigate. And I think this is also exciting because now you're taking everything that you learned from your fusion biopsy, even if you can't do focal therapy or they're not a great candidate, we can use this then to identify areas that are abnormal and then sample and then avoid areas where a positive margin could be. We published a couple papers on this as a 50% decrease in positive margins. Originally, the Italians were using PDF models to look at this, and they did a great job. They were really out front on this, and it's really exciting stuff to see this still coming through. And you're getting that idea and that picture from me. It's all about the care cycle management. It's the entire spectrum of prostate cancer treatments. You might be interested in focal, but all the technology from fusion biopsy and focal can now be reused and but just applied to surgical outcomes for that. So what are some of the outcomes for focal therapy? I think looking at the data, trying to pick the best treatment is difficult because every paper is slightly different. The cryotherapy data with fusion now, they're above 90%. The HIFU data is challenging because not all those patients had biopsies. overall, when we quote patients, we say about there's a 20% retreatment rate where you can have disease within the field or a secondary lesion appear. And those are just the challenges we have. Right now in the US, we typically do biopsy as tissue is needed as a endpoint at 6 months to 12 months when you're taking care of your patients. In Europe, they're using more imaging as a surrogate because really is, Mark Emberton and all the guys from the UK and Europe have spent more time in using imaging as a risk stratification tool. All we talk about in focal therapy is optimization of biopsy. How do we know where the disease is? And in the past, when it was just surgery, it was typically you have cancer, it doesn't look like it's outside the prostate, we're going to remove the prostate. And that is very different than how we approach things today. And with imaging, you may not need a biopsy because if it's not imageable, most likely that's not an expression of an aggressive disease. And with current data, we know that we have parity out to 8 years of HIFU and radical prostatectomy, which was really exciting out of the UK group. Physician training and certification. Now, all the vendors do have support for their modalities and using them in focal. We at Northwell, we spent a lot of time. All our physicians go through courses. We used to have twice a month for an hour a month. We go over MRI, fusion, segmentation, and targeting so people understand that. But I think it's important to have specialized training for your MRI interpretation, segmentation, regardless of the modality you're using, even if you're a surgeon. The mentoring and proctoring, we have metrics that we look at people, how they perform the biopsy, what are their outcomes. I'm going to show you how we check that. And I think it's a good learning tool. I am self-taught, right? I went through a fellowship, but we didn't really have all these modalities, so we picked them up as we went. My first time I segmented fusion biopsy in 2012 myself at my own institution, it took me 4 hours on the software that we had at the time. We've come a very long way. But after every case, I felt I learned a little bit more by looking at the MRI and learning through these steps. Finally, QA, assurance, patient-reported outcomes, tracking the outcomes, the complications, and I think being involved in this. I think it's really important. I'm going to show you how we do it, and I think you'll be able to do this as well in the future. But I think these are important steps with developing a program. So patient-reported outcomes, Epic 26 is pretty much the standard people are using today. The Epic 26 does take a little bit of time, but it's definitely a little bit more in depth and has bowel, hormone domains besides the typical things we look at for surgery. What's your complication rate? What's your positive biopsy outcomes? And what are your functional outcomes? These are all important. How many people in your practices are doing this on a regular basis consistently for all the patients in the practice? And this is a challenge, I believe, at any site to get all the patients to fill this information out. What did we do? Well, I'll tell you, I like to thank right now Ravleen and Cynthia now. Ravleen's our software engineer. Cynthia's my research nurse. We put a ton of effort and they put a significant amount of effort in our patient-reported outcomes. We have dashboards that now identify where the patient is in the cycle of care. Are they do a survey and did they fill it out? And then we can look at how those things change over time. And I think it makes it easier to lift. A lot of our patients said they love the idea. They get a text message before they come in. Did you fill out your survey? We start that 3 weeks before their visit. And if they don't, we have digital surveys they can complete on the office on their phone to try to keep the patient flow going. And then we give them information how we care about their outcomes and how we can change care by giving us feedback. They feel like they're involved in their care. The second part of this is how are people doing? I covered up some of the numbers, the names, but you can see the MRI volume growth over time. We're doing about 7,000 plus prostate MRIs a year for our urology practice. We break down patients by PIRAD score, highest grade group, and who's doing them and how are their outcomes. We have flags for people with skeletal muscle, non-diagnostic cores, bone, or even if a patient results haven't been resulted that we're expecting to see a result, we will flag that. This is part of our QA process to make sure patients are managed and we're looking at how people are doing versus the experts in the group and the averages. And this works for our urologists as well as our radiology colleagues. How often do they call a negative MRI? How often are they missing prostate cancer? These are the important things, and we have these feedback loops. Why is this important? Because we did a study about 8 years ago comparing two methods or two practices with the same radiologists. And if you read the MRI yourself and segment and target yourself, I believe there's a performance advantage. And when we did this, there was a 238% improvement in clinically significant cancer detected. So the work you put in matters and you will get something out of it. The patient, it's always, I tell everyone, you need to connect with your patient. They have to understand why they're going to choose focal therapy and what are the benefits and what are the pros and cons. And we go through this with all our patients. I think it's really important. They appreciate this. So take the time to get to know your patient, know what their fears are, address that, explain what the pros and cons of focal versus standard therapy or whole gland therapy so they can understand. We have tearaways. We have a prostate cancer booklet. We have a tearaway just to explain about the patient report outcomes, why it matters. And I think that's really important for us and for you starting a program. Here's a big summary of the funnel. We have the diagnostic pathway for elevated PSA. So we've created a way to help patients get through quicker. It used to take us about 105 days. Now we're less than 30 for a patient with an elevated PSA to a biopsy. We do QA for the MRI. There can be challenges. We try to address them. We have almost 18 sites we're doing MR at. So it's a hard job, but Anthony Pavone, my MR technologist, really puts a lot of effort into this. We talk about the shared decision, making sure they have a biopsy or not. Everyone must have fusion at our institution if there's an MRI visible lesion. I showed you our dashboard to look at the outcomes. We look at the outcomes of focal therapy, whole gland treatments, biochemical recurrence, positive margins, and try to tailor and optimize patient selection. And of course, at the end, I've harped on this, the patient report outcomes. When I first started, this was a challenge. And now I feel like we've lowered the bar to make it a lot easier to achieve these goals. Reimbursement, this is always comes up. This is a headache. Some are paid for, some are covered, some are not. Some payments are changing. Each vendor actually has a team that usually will help you work through the billing process to make sure you can get paid for the procedures. They take this very seriously because of course it affects their bottom line and they're always available. I think it's really important. And in treatments, we're not a cash only place. So we don't have the financial toxicity of people paying cash for these procedures currently because the majority of them are covered by insurance, which is wonderful for us. There's also discussion about fusion biopsy may have its own code in the future, which will only push focal therapy forward. And that's the end of my talk. I really appreciate everyone listening, taking the time. We're going to open it up to the QA session and hopefully let all my speakers in and get the chat function going. So I'm going to open up the chat's disabled, type answer. So Dr. Sanchez Salas is here joining us. I'm gonna get the QA turned on so people can write some questions in there. But Dr. Watts, you started your focal program a little while ago. Talk about some of the challenges and tips for some of our audience today.
Yeah, thanks so much for the question and for everybody who's joined the webinar today. I think one of the biggest challenges I found when I first started doing these treatments was figuring out how I wanted to talk to patients about it. Because if you're starting it at your program, it's something that's newer that patients may not have heard about, your partners may not have heard about or probably not doing. It's sort of creating your craft as to how you present it to patients in a way that's balanced and sort of evidence driven and fair. And I think for me that actually took a couple of years to sort of fine tune, and I crafted that based on talking to other people and, hey, how do you talk to patients about this and what questions have you found challenging? I think the other part that was challenging was getting buy-in from my partners. There are some who really like having this alternative for their patients and willingly will refer patients to me for evaluation. And then there's some who may never believe in this as an alternative, and sort of having that constant feedback of here's what we've been doing so far, here are the outcomes so far, and sort of highlighting the successes to encourage people to be aware of what's happening, what the successes are, and who may be appropriate patients to send to you for consideration.
Awesome. Yeah, I always forget about the buy-in. No one believed in fusion biopsy when it came out. I'm just so used to that pushback. Dr. Vourganti?
Yeah, I couldn't agree more. Um, there's I think the question was, what are some of the challenges? I think uh, as a field, the discipline has been growing so much, so there's new interest. It's an interesting though. A lot of people will have no understanding about different energies or really even understanding how I love how you laid it out. It really starts at the beginning, and if you aren't thinking about this from the beginning with the imaging and the biopsy, it's difficult. And so oftentimes people will be coming in from other institutions where they maybe had just a systematic biopsy or poor MR imaging, and their enthusiasm needs to be uh, for new ideas. It needs to be tempered. Um, I think that buy-in from your partners is important, and a lot of them are, as the 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 payer landscape changes and as their patients are coming in and demanding it, they're interested, but they don't necessarily want to take it on as a project. So every practice is going to be a little different, whether everybody's going to be doing it themselves or they're going to be referring to sort of a champion. I think at this point the field is so new, it is important for there to be champions, like you said, that sharing best practices, looking at how to succeed, because nobody wants to start this and after a while have either unacceptable oncologic outcomes or injury to neighboring structures and things like that that can really kill the burgeoning field. So.
Dr. Salas, Sanchez Salas is here. We have a question from an anonymous attendee. Do you allow patients to choose what focal therapy modality they want, or do you determine that on your own? And how do you choose? Like, where this is always a challenge. What do you have in the toolbox, and how do you pick the right one? And do you let the patient pick?
That is a great question. Well, first of all, thank you for having me, and thank you to the sponsor of the activity. This is a very appealing session. I would think that the energy needs to be decided based on its own benefits. And this goes with the operator experience and patient's expectations. Well, one of the things that we need to understand in focal therapy, and I repeated that many times, is that you need to be aware of the whole process. As you mentioned, MRI reading and expertise is essential. Biopsy expertise and performance is of utmost importance as well. But then the energy, you choose an energy that's gonna deliver the treatment, and you need to understand how seasoned are you in deployment that energy in the different parts of the prostate. I will definitely let the patient know what the options are, but I would probably suggest that based on the more or less experience I have with an energy, go for what I consider ideal for each specific case. You need to understand that there's no energy that is better than another one at this point, and whatever you do, you need to be autonomous. You cannot be driven by technology. We need to drive technology, and that's one of the important messages in focal therapy, because as we see, suddenly there every day there like the new energy that is going to take care of everything, and that is a wrong message for the patients. I think this is cancer treatment, and as being cancer treatment, is there are several pillars there that you need to take into account, and energy is just one of them.
Thank you. Yes, and I think Dr. Rafael Sanchez Salas is trying to tell you, don't just depend on the vendor. You need to understand how the technology works. It's not just pushing a button, it's taking the understanding of how that technology is applied to the patient and what things do you have to make up for while you're doing it. Is that what you're talking about, Dr. or Sanchez Salas?
I fully agree with that. I fully agree with that. Is the vendor is important because we have a close relationship with them. That industry and a physician symbiosis is very important because it creates a better product for the patient. But at the same time, you need to understand that at some point somebody makes a call, and if somebody makes a call, it's a uro-oncologist taking care of the patient, and it's the patient that needs to understand what are the pros and cons of therapy. And we have been through training to get to this point. We're trying to combine technology interactively in a disruptive fashion that is now is becoming more professional. So that we need to understand that there's still risk, and before it becomes more solid, you need to just stay on the safe side of the story.
I'm seeing a
So-
few questions from the chat that are inquiring, you know, which direction to go, which machine you should buy, you know, and I think that Dr. Salas pointed out that not one energy is better than the other. And I think that the right answer to that is going to be different for every institution and setting, right? So in that can be a little confusing. So in the same way that there are many choices, there are many paths to success. So really one energy, the importance is to get a track record with it, understand it. And it's going to be groups like this society you're going to be able to reach out to people, become active, go visit their ORs or participate in programs like this, our meetings, just to get started, right? So where you understand who's a good candidate, how you set up your biopsy in order to set you up for success, margin planning and whatnot. But getting really bogged down in which energy to do, a lot of times that'll be made for you. For me, a lot of it was which energies were around or were easy. You know, if you have a machine available, then you should probably start using that machine. I wouldn't necessarily spend a lot of, you know, political capital and financial expense on things that are difficult to get, because there's a lot of paths to success. Having said that, understanding the limitations of your specific energy that you're using can be important, because for every energy, there's going to be situations where whether it's lesion location or gland size or calcifications or prior treatment, it's not going to be ideal. So you don't want to start out with really challenging scenarios. You're going to want to be patient and wait for the good candidate, and then you'll find you'll be happy because you'll have good outcomes and you'll have happy patients. And from there, it's like any other expansion to your practice. You don't want to tackle the most challenging cases when you're starting maybe a new minimally invasive approach or a single port or new technology or whatnot. You want to find good candidates, start there, and then understand the limitations. So
just mark the answer that if you finish the question so we don't get lost. There's a ton of great questions coming up. I think the most powerful thing that's going to impact how you choose which modality is your friends, right? How are you going to go visit someone? Who are you going to call on the phone? And I think the Focal Therapy Society does a great job with networking and building those bridges for you. So please come to one of the meetings. We have resources for patients on the website. There's video. I'll get the link and put it in the chat so you have that. So we have patients resources for you to give to your patients to talk about focal therapy. And I think that's really where it starts. As every one of us on this panel, we all call each other. Like literally, I talk to Kara, Shri, and Rafael at least once a month. And we see each other at meetings. You develop those relationships. We want you guys to develop those relationships as well. And I think that's really what's important for that. Kara, is there another question on there that you want to tackle?
Yeah, I mean, there's really great questions coming in from the audience. I think you just addressed the one about shared resources and care pathways from FTS. And so the next question is, can HIFU treat all regions of the prostate? There's two forms of HIFU. There's transrectal and transurethral HIFU. Sonoblade is transrectal HIFU. And no, it can't. It depends on where the lesion is. So the transrectal HIFU, like Sonoblade, really can sink the highest energy in the posterior aspect of the prostate. And you have to think about applying a margin around the cancer as well. So, we roughly suggest about 3 centimeters max anterior length from the posterior capsule, but obviously this depends a bit on each patient case. Transurethral HIFU does have an added benefit of being able to kind of treat circumferentially around the urethra, so it can hit some of those anterior tumors that the posterior transrectal HIFU cannot. The limitation or perhaps the challenge with transurethral HIFU is that it's done in an MRI scanner. It's MRI driven, so you do need to be able to have the logistical setup to be able to do a treatment in a magnet. And so for some centers, being able to get anesthesia, equipment, everything into an MRI scanner to deliver the treatment can be a little bit more challenging.
And that question probably comes from the days of the quote unquote a la carte type of approach, which we do not believe in. So, HIFU does have that limitation of how far, but most prostates, as long as you make sure your margin goes past their recommended, or it does not exceed the recommended depth of penetration, you can treat a lot of the areas of prostate. Size matters. Size impacts the choice. Calcifications and those things. But I'm going to tell you, what causes the most failures in focal therapy is a really poor diagnostic process up front. Most of the failures that I have on trial are from referrals for focal, not me doing the own biopsy in my practice. I think that's important. Steve Canfield, someone asked about guidelines and he says they're coming. Why does Steve know? Because Steve is our focal therapy board member that's involved with pushing this on the guidelines. So it's really exciting that that stuff is moving forward because there is more data. Everyone's going to be a critic, and I think we need to maintain our scientific integrity and do good work. And it's through our publications and our collaborations that we're able to push this forward. Dr. Sanchez, Salas, you want to answer one of the questions you see on the side, or pose one yourself?
Yeah, I wanted to comment on the guidelines. It's an issue that will come over and over because the people need that specifically guidance. But the guidance as we see them today are like God's lines, and this is not how you treat patients. These are not God's lines. What you get from EAU or AUA or patients are coming to ask or requesting for focal therapy because there is an option for quality of life maintenance, and this is something that should be tailored with the risk that you can take. And that goes exactly with it. That's an energy can do everything. Obviously, if you talk to people like Tom Polasic or Erle Lepore, they will tell you that they have this energy they master at such a high level they can go anywhere and get good result with a single energy. If you're starting with your program, but definitely you need to use whatever you have available and explore what are the options and how you feel more comfortable, and develop a line of treatment and clinical and research that allows you to feel solid in what you're proposing to patients. But I think that definitely this a la carte is something that's most likely in the past. I defended it many times because it came from the institution that I was working in France. But definitely, we have data from Lara Rodriguez Sanchez and Fernando Bianco that is telling you exactly the contrary. If you are seasoned expert and you have rational thinking, one energy can do it all.
Thank you. I want to give this one to Dr. Vourganti. What are the limitations or your thoughts on IRE, irreversible electroporation?
Yeah, so IRE, at least in the United States, is somewhat of a new kid on the block. It's probe-based, so it's a transperineal set of series of probes. I find that some of the strengths of it are that urologists, particularly urologists that are getting into focal therapy, they're mastering precise placement of needles, right? So if you can't do a if you can do a good fusion biopsy, the same thought process of just precision placement of needles can play out. Essentially, what you're doing is you're placing these electrical probes and their exposed electrodes, which you can control the length of that exposure around the area of interest. It is flexible in terms of it can treat both the posterior and anterior prostate. It is resilient to calcifications and those challenges which can impact HIFU and other energies. However, it's not I wouldn't say that there's one energy that's definitely better than any other. For instance, you might hear that it doesn't heat the tissue, or maybe believe that it's impossible to hurt. But even in the U.S. based trial, there was one fistula in 130 patients. So we still need to be using our oncologic thought processes. We're going to be needing to choose the cases wisely, monitor the patients, and whatnot. But I think that I found it to be a very flexible energy. I've been able to use it throughout prostates of varying sizes, and I think that if you have access to it, particularly if you have a paired fusion platform that can help you place these needles precisely, I think that you'll find good outcomes, and I think your patients will enjoy it.
I would like to make a comment on that. The magic word that for IRE is fusion. What would be the opinion of the panel of an IRE treatment without fusion? Cognitive IRE treatment. I have second thoughts about it, but I would like to hear what you guys think.
Yeah, I was surprised. Even in the U.S. based trial, many programs weren't using fusion, and I believe that fusion at the time of diagnosis and at the time of treatment is quite important to avoid marginal failures. And I think that if you look at the data is rife in situations where there's just a lot of marginal failures and infield failures. And I do think that many of these can be avoided with good fusion. I feel like many of these treatments, even the best people that are looking at MRIs and then looking at ultrasound, the precise placement of the margin in what I would call the Z-axis. A lot of people are looking at the axial imaging, looking at I'm putting this right where the MRI says it is, but how do they know that the treatment effect is going to go base enough or apex enough? And I think that can be many of the marginal failures. The other piece of the puzzle, the challenge that can happen is that with these probes, I think that they're, as designed, they should be deployed within the prostate. And as we know, the prostate is not a cylinder, it's not a square, it curves. And so it has some strengths in that it's not, it can deploy a treatment energy, but when you get to the edges of the prostate or whatnot, sometimes you're going to have some challenges putting in some of these probes without having part of the electrode be outside of the prostate. And I think that these are situations where, particularly in the posterior prostate, you're going to be having some unpredictable application of the energy. So these are definitely challenges, and I think that they can be overcome with the application of fusion. And so I could not emphasize that stronger. So
I think the only thing I would just add to that, and I agree with everything you just said, Shri, is that, I think you have to take it on a case by case basis. I mean, I think there's plenty of people who want to get into or are starting in focal therapy and their practice or their group just can't afford like an image fusion system. They're not cheap. And rental basis is not cheap either. So, if you have a small prostate and you are really skilled at looking at ultrasound, transrectal ultrasound, and feeling comfortable with looking at prostate MRI and really spatially orienting yourself, there are times when you can reasonably do this without fusion. If you have a really large prostate and you're trying to target a pretty small tumor, anteriorly, it's sort of like spatial reasoning. What can you do safely within reason, and what would you probably do slightly better with some assistance. So I think there's no real black and white, but just kind of take things on a case by case basis.
I just when we first started, you try to guess, can you do cognitive? Is it there? And then we put the fusion on and see how off we were. And you're off 15% of the time. And then if you add that for focal, where's your margin? You're going to have a higher error rate on that. The bigger the prostate, the more real estate, the higher the error rate. That's the challenge. I do recommend that anyone that's getting into focal, if you're doing transperineal probe-based therapies, transperineal biopsy, do 20 TP biopsies of fusion. Realize that what you see on the MRI may not be the same as what you see with your orientation with respect to the rotation in the sagittal plane forward or backwards, because the rectum pushes, you can push the probe up too much and rotate the prostate forward. There's a lot of play in there that you have to really get those fine nuances for. One of the questions was, how do you get buy-in from radiology on these teams? The way I've done a lot of my work in building these collaborations, I should get them to see value, right? How do I have my radiologists excited about it? The amount of growth you saw in our QHR, we're doing over 7,000 prostate MRIs a year. That's a pretty significant amount. On top of that, we help them optimize their billing. So they're using the CAD like they're supposed to. They're creating our color maps for us. Those things get billed as well. They have revenue associated with that. We have a pathway that they segment and target anything that's 3 or higher. We order that in the time of MRI, so it's done for us, so that flow works. It doesn't interrupt them as much. And that's just going to segment into the discussion we have next of our 3 other panelists. Is there preferred AI platform for mapping or ablation planning? And I'm not going to answer till after I hear from everybody else.
I think that AI is definitely the future for everything, I guess. But there is a nice publication from the MIT that is saying that the people that are writing papers with AI, they're not developing enough ideas. And it's just, I read that, and I told myself, this is the same thing. If you're starting to trust AI to do your contouring and your MRI reading, when are you really going to contest MRI calls from the radiologists? Obviously, it's not our field of expertise, but we need to be able to interact with radiology. We need to be able to read an MRI, understand that there's a huge tendency towards biparametric MRI, and for us, for the treatment we're doing, we might need this contrast at some point for evaluation, for a sound assessment of prostatic tissue. So I think AI is good. It will save you time, but definitely there is a learning process that needs to be done, and cutting corners in this is not, I wouldn't think is the best idea.
Yeah, I would even add to that, Rafael, I agree completely that even if you're using image fusion, to do your biopsies, for example, you can't just completely trust the technology, because, I've done image fusion biopsies where the lesion is outside of the prostate. It doesn't even make sense. And so you still have to use your brain and your understanding and your skills and be active in it and be able to adapt and work with it. If you only rely on the technology, then there can be issues with that as well. I have a question for the other panelists, if you sort of following up on something that Art said before about perhaps some of the failures were from outside referrals. So I was wondering if any of you wanted to speak about how you handle outside referrals and when people send you in with their biopsies already done, how do you approach that?
But you have a selected group of people that refer that you can trust, and then you understand that the quality of the information you're getting is high, or at least what you need to follow on patient care. But if you have the list, what I have when I have the list out on what I'm getting or what I'm seeing, I'll just go over with the whole process again. It is sometimes painful for the patient, but you need to explain that the actual outcomes should be sustained by the selection process. And if this is not good, obviously the results will just be lousy, and patients normally understand.
Yeah, I think that what I tend to do, Dr. Watts, is I'll break it down to the patient, because starting over sometimes is required, for sure, because if they just don't have image localization, or a good quality MRI before, or a biopsy that makes sense, then sometimes you have to. I always feel better when I'm doing the fusion ahead of time, or if I'm doing like a biopsy that's specifically designed to the vet focal therapy, but the patients don't always want it. So if they come in with a decent MRI and a target only lesion, and it's and if everything's lining up and they're a good candidate, I tell them, I didn't do it, I don't know how, it's not exactly how I would have done it, but do you want me to repeat it? And that's some patients say, oh, absolutely, I want you to repeat it, and I want you to vet this, and others want to go forward. And I think that's a reasonable thing to leave the uncertainty to the patient, and sort of explain to them what those uncertainties are.
So at our institution, we all do fusion biopsies the same way on the same system, and it uploads a video to the cloud. So we have it stored so I can see how good that fusion was. And then we have also the 3D map that's pushed back to our CAD system, where we're able to look at each core where it was. We have a still shot of each core that was acquired. Do they have good co-registration or not? Last week, one of my partners sent me some cases for focal. I've accepted them. And this one, I was like, your co-registration was too far off. I know you hit the target. However, I can't trust the rest of the biopsies. How close was it to the lesion? Did you have any perilesional sampling? I used my 12-core biopsy to see. Maybe I'll put the core just a further out than where I put the margin to make sure there's no cancer there. So I'm always thinking that this candidate's a focal when I do the biopsy. And I don't think that always happens when other people do the biopsy. And the thing about the AI platforms, I want just you guys to all be informed. There's a ton of claims. What they claim and what they say is very different than what's written down, because they have to be compliant, at least in the United States, with their what they can market for their product. What were the metrics set? There's all these people out, oh, AI is amazing, but the threshold is 0.5 cc's to detect a lesion that's clinically significant. In the focal world, is that big or small, guys? It's enormous, right? It's 1 centimeter
Huge.
across. Clearly, we don't need AI to find a 1 centimeter lesion. However, that's where they look at where their performance is. So I think it's a little scary and dangerous not to understand what's under the hood and what is it really assessing. And we see that happen a lot. We see there's companies that say they do lesion segmentation and risk stratification, but that's not exactly what their original clearance was for. So there's a lot of different companies coming into space. I think it's an exciting space. I do research with Anant Matabushi down at Emory. We're putting stuff out all over the place. It's a lot of fun, but you have to understand where you're drawing the metric of what success is for each one of these technologies. So we have 4 minutes left of our open discussion. That was a quick hour. Before we finish, I just want to again thank the Sonoblate team for supporting this endeavor, and we'll put this on our YouTube channel. But I want to go through everyone. Last closing thoughts. Dr. Watts, Dr. Vourganti, and Dr. Sanchez Salas. Dr. Watts.
Oh, I'll start. Yeah, I would just thanks so much for tuning in and for the opportunity. And I would just say I can't emphasize enough the importance of connecting with people in the field and finding mentors as well as sponsors. You know, someone sponsor is very different from a mentor. A sponsor who's going to kind of help you within your group or your institution navigate the financial aspects of this, and you're going to need capital to get started. It's just necessary. And your mentors, people to train with, ask questions to, reach out to. It's so important, and it helps give you confidence as you build your experience over time.
Yeah, I can follow up on that. I First of all, I want to. There's a great turnout, and I encourage people to and thank them for their enthusiasm. I think that uh, we learn so much from each other, and many of us are beginning at this, and there are people that have been doing this for 15 years with success, and so learning from people's success and not making the same mistakes that have been made in the past, which are unnecessary. Your patients won't need to do that. And so my personal experience has been that you can reach out to people. They're very open, and we intend to continue that spirit, which is really the whole point of having a focal therapy society at all. So don't hesitate to reach out to each and any one of us, and then and I do predict that as you begin these service lines, you're going to have happy patients, because we all have very, very happy patients throughout this. And Art mentioned this, the amount of regrets that people have, even if they learn about it and they think about it and they go in a different direction. I think that they have less regret down the road, because then they feel like they owned the decision. So
I would like to thank our sponsor once again for this great opportunity to inform our colleagues about focal therapy. In the Focal Therapy Society, we think that keeping an open mind is essential, as said, to learn and to be able to bring new ideas to the table. We just need people to have different ideas and confront these ideas with what we think. And this open-minded approach is what is probably take focal therapy into the future in a more solid fashion. Thank you once again.
Thank you, everyone, for taking the time to join us today. Thank you to Sonoblade for sponsoring. Again, let's thank our panelists. I really appreciate everyone taking the time out of their busy day to come. So thank you again to everybody.
Thank you, everybody.